Cancer is the most life-threatening situation that children face after the neonatal period, except for accidents. At the 1968 meeting of the American Radium Society, one aspect of pediatric cancer is on the program for this reason, and also because the treatment of solid tumors in children requires the joint services of surgeon, radiotherapist, and chemotherapist. And all three of these disciplines are represented in our membership.
As a professional education extension of the 50th annual meeting, the American Radium Society presents Childhood Cancer, Current Outlook. Participants are Dr. Lois Murphy, Chairman of the Department of Pediatrics at Memorial Hospital in New York. Dr. Lester W. Martin, Director of Pediatric Surgery at the Children's Hospital in Cincinnati, Ohio. Dr. Melvin Teff, Radiotherapist-in-Chief at the Children's Hospital in Boston. And, as moderator, Dr. Lemuel Bowden, Associate Attending Surgeon at Memorial Hospital in New York City.
Obviously, in the time allotted, it would be impossible to comment even briefly on every type of solid malignant tumor of childhood. And we have agreed to confine our remarks to three of the most common ones, namely Wilms tumor, neuroblastoma, and embryonal rhabdomyosarcoma. The first case that I'd like to present is that of a 9-month-old baby boy who was noted approximately 1 month before hospital admission to have a slowly increasing abdominal girth with some distension of the superficial veins of the abdomen, but was not noted to have an abdominal mass until the day prior to admission. An immediate IVP was secured, and this revealed the presence of a lesion of the right kidney. On the basis of this brief history, Dr. Martin, how would you go about managing this case?
This particular Wilms tumor is an ideal candidate for immediate operative removal. The origin of the tumor from the lower pole of the kidney tends to displace the renal pedicle upward somewhat and creates a bit more of a difficult operative approach for the surgeon. A point could be made for a thoracoabdominal approach in this particular child. Ordinarily, as seen in the photograph, we prefer a transverse abdominal incision extending from one flank to the other, providing generous exposure and permitting early operation of the renal pedicle in the course of the operation. The location of the tumor within the kidney is of more importance to the surgeon than is the size. As seen in the next photograph, a particularly large tumor may be removed with relative ease. We feel that during the course of the operation, the opposite kidney should be examined carefully. And the one shown in the next photograph, the tumor on the opposite side may be particularly small and can be detected only by careful examination of all aspects of the opposite kidney. Bilateral involvement can be expected in approximately 10% of the patients with Wilms tumors. We feel that the operation is not complete until a thorough retroperitoneal lymph node dissection has been carried out. Occasionally, the tumor is spread to the retroperitoneal node prior to its spread to the lungs or elsewhere.
In an early case, such as this one we have just detailed, do you feel, Dr. Teff, that there's any place for radiation therapy? And possibly you would also comment on the possibility of finding positive nodes or extrarenal extension at the time of surgical expiration, and thereby, or in such an instance, the need for radiation therapy.
Well, in the younger child, especially a child under 13 months of age, with a good overall prognosis, when the tumor is well encapsulated and with no evidence of break in the capsule, when there is no lymph node involvement, and when there is no local vascular invasion, it is not our policy to use routine postoperative irradiation. However, when any of these other things are true, when these things are positive at the time of initial surgery or in the older child, when radiotherapy is used, the volume is carefully tailored to encompass the tumor-bearing tissue and to minimize the radiation to normal growth structures. The dose is consistent with both control of the tumor and adjusted to the tolerance of normal tissues in the growing child.
Dr. Murphy, in an early Wilms tumor, what place is there for chemotherapy?
A commonly accepted practice is to start a course of actinomycin D on the day of operation. Many centers then give repeated courses of actinomycin D at intervals of 6 weeks to 2 or 3 months for 1 year. In our institution, the first 2 doses of actinomycin D are given before operation, together with 2 doses of radiotherapy over the tumor. Following operation, the remaining 3 doses of actinomycin D are given, and the radiotherapy course continued. Repeated courses of actinomycin D are given at intervals of 2 to 3 months for 1 to 2 years.
Of course, the idea behind such therapy is to prevent, we hope, the possibility of metastases. If metastases, however, do occur in a Wilms tumor, does this mean invariably a completely hopeless prognosis, Dr. Murphy?
No, there are many children who have received chemotherapy and radiotherapy for metastatic Wilms tumor who have had disappearance of these conditions and are well at the present time.
And is there any choice, do you think, between the chemotherapy and the radiation therapy in the management of such metastatic lesions? Or do you think it's entirely a combined endeavor?
I think it should be a combined endeavor, and of course the lesions may be excised surgically if they're discrete.
I was going to ask that of Dr. Martin. In the case of a solitary pulmonary metastasis from Wilms tumor, do you think it's very often that it is in fact solitary and that there is a place then for surgical approach and segmental excisional lobectomy of such a solitary metastasis?
In answer to your first question, I doubt that any of them are solitary. I suspect that most of them are multiple. We feel that the initial metastatic lesion should be treated by a combination of radiation plus chemotherapy. In the occasional instance, one single lesion will recur following this course of treatment or will persist in spite of combined therapy. In that instance, we do advise surgical removal. And in case another one should recur later on, we would remove that. We've had one child that has had 5 separate resections, removing only a small amount of lung tissue with each particular tumor, and the child has now had over 5 years since the last resection.
Mm-hmm. Dr. Taft, do you care to comment on the management of metastatic Wilms tumor?
I would agree completely with Dr. Murphy that the first attack, and with Dr. Martin, that the first attack would be a combination of radiotherapy and chemotherapy for the first evidence of metastasis. And certainly there are some children who do have solitary lesions that have survived after excision. I think the only point to make is that when one does irradiate the lung fields for metastasis, one includes the total volume of both lungs, both apices and bases.
First case, being a relatively early example of Wilms tumor, probably carries a very good prognosis with it. Unfortunately, this is not the case with all childhood tumors. And for the next case, I'd like to present that of a 7-month-old baby girl who was found some 2 months before admission to the hospital to have likewise an enlarging abdomen and was noted to have an abdominal mass in the left upper quadrant shortly before admission, at the same time as a mass in the left groin was identified. The small mass in the left groin was removed for histologic study and proved to be metastatic neuroblastoma. An IVP is secured, revealed marked distortion of the left kidney position because of the presence of a large suprarenal mass with flaky calcification contained therein. Furthermore, a marrow aspiration in this child revealed the presence of extrinsic cells consistent with metastatic neuroblastoma in the marrow, although the skeletal survey showed no definite evidence of bone destruction. In a situation of this sort, Dr. Taft, Would you comment as to how you would approach the problem therapeutically?
Well, in a child under 1 year of age, due to the distinctly better prognosis as compared to the older child with neuroblastoma, even such evidence of disseminated disease, every attempt is made to control the disease that is encompassable by irradiation and at doses tolerable to normal growing tissue. Therefore, after biopsy and possibly after surgical removal of the suprarenal primary, we would advocate irradiation of the suprarenal fossa and the node-bearing areas in continuity with this involved groin node. In advanced cases, in older children, when there is diffuse bone destruction by X-ray, we would deliver more modest palliative doses of irradiation to the local site.
May I ask Dr. Martin, would you consider immediate surgery on the primary tumor above the left kidney as a surgeon? Or would you prefer possibly to ask your radiation therapist colleague to give preliminary radiation therapy before attacking this surgically, or would you attack the primary tumor surgically at all?
In this particular child with evidence of metastatic disease in the bone marrow, we would feel less urgent about operative removal. If we had a negative bone marrow, we would approach this aggressively and go immediately and remove the tumor. With a positive bone marrow, we would discuss this, the members of the team, and come to a decision. And I expect that we would probably remove the primary and then use combined radiation and chemotherapy.
And Dr. Murphy now, the question of the involved bone marrow has been upmost in the minds of all of us. In this particular patient, would you comment on the significance of this and the treatment of this chemotherapeutically if you feel this is what should be done?
I'd like to reemphasize what Dr. Tebb said, that the prognosis in such a patient is grave but not hopeless. Neuroblastoma invading bone marrow has similarities to acute leukemia. Treatment should be selected to eradicate the extrinsic cells. Thereafter, normal bone marrow cells return. Neuroblastoma cells can be suppressed within a few days by the more vigorous chemotherapeutic agents. For example, a full dose of nitrogen mustard, a course of actinomycin D, or high doses of cyclophosphamide. There may result hyperuricemia, temporary severe thrombocytopenia, and leukopenia. To treat with these agents, the child needs to be prepared with good hydration and allopurinol to prevent hyperuricemia. In addition, if bleeding develops, platelet concentrates for supportive management may be required. If leukopenia is severe enough to lower the circulating granulocyte count to 1,500, a strict isolation to guard against infection may be necessary. Now, the normal bone marrow should regenerate within 2 or 3 weeks, following which a maintenance schedule of weekly alternating doses of cyclophosphamide and vincristine can be used. If one is not able to give heroic supportive therapy to such a patient, the latter 2 drugs can be used as the initial treatment, and some good results have been observed with them. Some kind of chemotherapy certainly should be given for probably 2 years. The catecholamine excretion in the urine, as well as careful physical examination and serial bone marrow examinations are helpful in determining activity of the neuroblastoma during the course of treatment.
Knowing, of course, the hematopoietic depression effect of most of the chemotherapeutic agents, I think some practitioners might rightly fear the use of massive doses of any of the chemotherapeutic drugs if it appeared that the marrow had been largely replaced by extrinsic tumor cells. Would you comment on that? Do you think that is a contraindicating factor, the degree of marrow replacement, in other words?
Well, this fear is certainly justified, and we all share it. However, these neuroblastoma cells must be removed from the bone marrow before there can be a remission and return of normal elements. So it takes a good deal of clinical judgment in determining how much of an agent a given patient can tolerate. It has something to do with a marrow reserve in a given child.
One comment I think that certainly should be made with regard to neuroblastoma is the fact that in occasional instances there will be, of course, spontaneous regression of the tumor that is currently not completely understood. And for that reason, too, I think that a totally hopeless prognosis should not be given even in an advanced case such as we've just seen. Now, I'd like to go on to one third case, if I may. This is that of a 10-year-old boy who 3 weeks prior to admission to the hospital was noted by his mother to have a painless mass in the right arm fixed to the bone, or seemingly fixed to the bone, and just distal to the elbow. He was seen by his local physician and promptly referred to the hospital in the suspicion that this might be a malignant tumor. At the time of admission, this mass was noted to be a fairly good size, 5 by 3 cm firm infiltrating mass, and at the same time, 2 or 3 definitely enlarged lymph nodes were identified in the axilla of that side. Assuming, as was the case in this patient, that the lesion proved to be an embryonal rhabdomyosarcoma, would you comment, Dr. Martin, on your approach to this problem?
This is a particularly difficult problem. The fixation of the mass to the bony structures of the forearm preclude local excision as a means of treating this as a definitive surgical procedure unless we are quite radical in our approach. The spread of the axilla, again, means we must be more radical. I believe the only way we could approach this surgically, other than to obtain a biopsy, would be to do a 4/4 amputation, which is admittedly a rather mutilating operation for a small child faced with the 65 more years of going around with a 4/4 amputated. Now, I would choose between that or biopsy only and using other modalities such as either radiation or chemotherapy as far as the definitive management. I believe the only operation we could do would be a 4/4 amputation as a curative type of procedure.
I'm glad to hear you say that because I think cure is possible even in this particular presentation by such radical surgery. But I'd like to ask Dr. Taft if he feels there's any place for radiation therapy in the management of this particular patient.
Well, as Dr. Martin has indicated, this is indeed a very difficult problem. Irradiation at high dose, especially when combined with chemotherapy, has resulted in marked regression of some of these lesions. But when the disease can be removed surgically, lest there be local recurrence, since one cannot be sure of total eradication of all cells in this particular lesion, it might be as well to do such a radical procedure as Dr. Martin has indicated. In other areas, such as the nasopharynx, when total surgical extirpation is usually not possible, then radical high-dose irradiation, when combined with chemotherapy, has indeed resulted in the survival in some patients.
Dr. Murphy, would you comment on the seeming influence of primary location of the embryonal rhabdomyosarcoma and prognosis, or possibly even treatment?
Embryonal rhabdomyosarcoma may arise from soft parts of the head and neck, the genital urinary tract, the extremities, or the retroperitoneal areas. The prognosis is somewhat better when the origin of the tumor is in the head and neck area. Chemotherapy of choice for embryonal rhabdomyosarcoma is actinomycin D, cyclophosphamide, and vincristine also has some beneficial effect. This tumor invades the bone marrow, and therefore marrow examination needs to be carried out before the chemotherapy is selected.
And in this particular instance, may I ask, assuming that a 4/4 amputation were done, would you recommend in the postoperative period that any so-called suppressive chemotherapy be administered? This is a leading question, but I'd be interested in your thoughts on the matter.
Well, the frequency with which this tumor metastasizes widely, including replacing the bone marrow, I think it's worthwhile to consider a so-called prophylactic chemotherapy in this condition, give repeated courses of actinomycin D, or perhaps I think this is a good situation to use combined chemotherapy. There's been some interest in actinomycin D together with vincristine, and we've given actinomycin D together with cyclophosphamide in repeated courses in an effort to
over the course
continuously,
of a couple of years or more,
in order to continuously suppress this tumor.
I see.
Certainly along with X-ray therapy and surgery.
Mm-hmm. Dr. Martin, would you agree to that? Or did you have any other comments?
No, I think I would agree with that. One particular child with a rhabdomyosarcoma of the orbit, which we see the slide on, with metastasis to the local area, was treated with a radical operation exhibiting the orbit, primary closure of the tissues. The metastatic lesions were removed by only local removal, and the child was treated with deep radiation to the neck, and the node disappeared completely. It's only been 19 months since the procedure. We still feel that the prognosis is poor, but such a hopeful occurrence makes us feel as though it's not an entirely hopeless disease.
I think many of us have the impression that possibly embryonal rhabdomyosarcoma arising in the head and neck area may be a little more responsive to radiation therapy than such tumors arising elsewhere, and may have a little better prognosis, although this is very difficult to prove statistically. Would you care to comment on that, Dr. Kapp? Do you think they have a somewhat better prognosis?
I think that I agree that it is difficult to analyze this statistically because the patient numbers are so small, but one's impression is that this is indeed true.
Mm-hmm. Are there any other comments any of you would care to make about this case? If not, in summary, then, I think we have presented three fairly typical cases of solid malignant tumors in childhood, and their treatment has been most ably discussed by my panel members here. I think it is worthwhile to note that current practice favors the combined therapeutic approach in which the capabilities of several medical disciplines, surgery, radiation therapy, and chemotherapy, may be and frequently are utilized in the management or in the total care of these patients. Childhood cancer is happily not common, but does rank as the second most frequent cause of death in children past the neonatal period. With early diagnosis and with skilled and dedicated treatment, however, a favorable outcome may be anticipated in a substantial number of these patients.
This program, Children's Cancer, Current Outlook, was produced by the American Radium Society during its 50th annual meeting in Miami Beach, Florida, April 1968.